Good evening, everybody, and welcome to tonight's In Conversation live at the Royal Society of Medicine. We will be in the company of Dame Clare Gerada. My name is Henrietta Bowden-Jones. I'm the President of Psychiatry here at the RSM. Hello, Clare.
Hi, good evening.
Thank you for joining us tonight. Now, it's a very small group. According to the size of your usual audiences, there's only just over 1,000 people tonight listening, so intimate. We'll have a good chat. Please, could everyone use the Q&A function if you want to participate. It's going to be a very lively evening. We're going to cover several topics, and please do contribute whatever you would like. Great, so I'm going to move on to Clare's biography before we start with questions. After qualifying in medicine, Dame Clare trained in psychiatry at the Maudsley Hospital before following in her father's footsteps to become a general practitioner. She has worked in her South London practice for 30 years. During this time, alongside her clinical practice, she has held a number of national leadership positions and has led the way in reforming how drug users are managed in general practice. She was awarded an MBE in 2000 for her services to medicine and substance misuse. She was chairperson of the Royal College of GPs in 2010 for 3 years. She's been instrumental in the development of services for doctors and dentists with mental health problems and is a medical director of NHS Practitioner Health. This service has been hugely impactful, particularly on young doctors and consequently on the patients they look after and the teams they work in. The service was awarded outstanding by the CQC ratings in March 2019. Dame Clare has also established a service of problem gamblers and chairs a newly formed registered charity, Doctors in Distress. She's also co-chair of the NHS Assembly and was awarded a DBE in the 2020 Queen's Birthday Honours. So welcome again, Clare. And let me start by saying that you are the ultimate Dame. I have never in my interviewing life been told by someone in 5 minutes before they go live exactly what questions to ask and in what order. Too late, I've got my questions. Very good, but lovely. So let's talk about your early beginnings. You were born in Nigeria. How did that come about? You're half Maltese, your dad was a doctor. Tell us a little bit about those early days.
Yeah, I'm not half Maltese, both my parents are Maltese.
You're wholly Maltese.
So Dad qualified as a doctor and did his house jobs, and on the day after he qualified, he left with my mother for Nigeria, ostensibly for an 11-month locum. I'm not sure it was called a locum in those days, and he was a sort of tender age of about 27 and my mother was 21, so they left for Nigeria, albeit for 11 months, and stayed 15 years, and 4 children later came to the UK because they'd never lived in the UK, and so I was born there with my siblings, and then another sibling came afterwards when we were settled here in England.
Mm-hmm. And so you grew up in the household of a doctor, and how was that? I mean, you're a doctor yourself now. Tell me a little bit about life as it was then.
I mean, Dad, having spent 15 years in Nigeria, was very, very well qualified in infectious diseases and children's medicine, but he had to come back, and like many immigrants, international medical graduates, he struggled to find a job. He did get a job. He got a job in Peterborough, where there was a large Italian community, and he spoke fluent Italian. So he got a job as a GP, initially looking after as a single-handed doctor. So in those days, the surgery was our home. So the living room by day was the patient's waiting room. The dining room was my dad's consulting room. The entire house had the trappings of medicine. I even would play with the skeleton, a full-size skeleton. That was my doll, and I used to dress it up. So, and patients just were part of my life. They were completely inseparable to me. I mean, they were there. My earliest memory is, or one of my earliest memories is peering over the balcony and seeing all these women, and they always seemed to be women and snotty children crying in what was my living room. And I'd learned to tiptoe upstairs, never to shout out, to behave in the streets because I was the doctor's daughter. So, and he used to take me on home visits, Etta. I mean, as a young child, I mean, we're talking about 9 or 10, Dad would take me on home visits to what was then still the sort of post-war slums of Peterborough. And I used to love it. I used to wait in the car, and he used to sort of come out and tell me what the visit was about. And if I was really lucky, I was allowed into the home and maybe see a child with measles or other infectious disease. And he really instilled in me a love of medicine and in particular a love of general practice. And I didn't understand it. He didn't use these words, but this is how I translate it with my adult voice, is that he taught me about the social determinants of health. He taught me that to be a good GP, you had to be part of the community. And he also, he sort of, my dad was one of the most humblest men you would ever meet. He really instilled that I was very lucky because I was clever and I should give something back. You know, that's what I had to do. And being an immigrant, I had to do better than my peers who were born in this country. And yeah, so I became a GP, I mean, en route to doing psychiatry. And finally, so much was I did in general practice or in medicine, but Dad used to do a lot of postmortems in Nigeria, you know, not here in England. And he had all these books on postmortems. So I got fascinated in looking at murder and how you distinguish causes of death and strangulation and drowning. And I once can remember taking one of these books to school and showing my best friend all these pictures of dead people, and she fainted and the book was confiscated. The last time I ever took any of my father's books into school.
Oh my God, that's such a great story, and you know, and really, really strong impact in terms of seeing it firsthand. So, how old would you have been? Were you always, in terms of making a decision about your life's course? Did he ever openly encourage you, or was it more a nurturing and a showing by example?
There was never any doubt in my mind, fortunately, because there was a lot of doubt in my teachers' minds that I was going to be a doctor. And except once when I saw a picture of our school didn't do careers advice, but I saw a picture of a High Court judge, and she was a woman, and I thought, oh, I fancy that, but fortunately I didn't, because even now I don't think there's many female High Court judges. No, I mean, I talk about this in some of my writings, that medicine for me is something that you are, not something that you do. And my identity as a doctor was started at a very young age, and it continued. So as these patients invaded, if you like, my home, I learned to separate from them. So I learned to answer the phone with authority. So, hello, 54885, Dr. Gerada's daughter. Now, I was doing that at 9 or 10. So it was something that was, you know, it's not right nowadays to talk about vocation, but it certainly was a vocation for me. Now, it was fortunate because, you know, being a doctor, even then, getting into medical school was tough. And the only careers advice I wasn't given, my stepmother was given, which was, Claire will never get into medical school because she's too outrageous. And nothing's changed. And my stepmother sort of asked why, and she said, well, she wears striped stockings. Now, in those days you wore striped leggings, it was a fashion. And so I
remember that I had a pair. Yes,
exactly. And I think that I was never earmarked. I was never a leader. I was clever, but so it wasn't a very good comprehensive school that we went to. So but I was determined to be a doctor. There was absolutely no doubt in my own mind.
Claire, before we move away from your parents, a couple of things I want to know. I want to understand whether there were some character traits, some strong bits of your parents that you carry within you.
It's not that I carry my parents within me, it's just that what shaped me, like what shaped many people probably listening to this, is through your life you face adversity. Through your life you face things that shape you in later life. So I certainly didn't have helicopter parenting. I certainly didn't have my parents looking over my shoulder for my homework. I barely remember them being involved in any of my sort of schoolwork. And so it's not so much that they shaped me. I learned to be self-sufficient. I mean, my father, of course, my mother shaped me. My father was a very good GP, and I wanted to be like him, though, of course, I didn't go into general practice because I didn't want to work in his practice. But it's difficult to say what values they gave. My values came clearly from my father and his love of medicine, and my father from his deep commitment to the patients that he served. And my mother was, in retrospect, one of the most intelligent women that I think I've ever met. She was she learnt to play bridge when she was 40 and became a bridge champion, and played well into her late life. I mean, well into her 80s. She was winning bridge tournaments, and an astonishingly clever woman.
And competitive, Claire, and competitive. If
my
she
mother was
champion of bridge, surely we will grant her that. So if I go back to something you just talked about, you said daughter of immigrant parents and needing to be even better because of it. Can I just dwell for a second on what you meant by that? Was there a feeling of
I mean, it seems strange now when we look at all that goes on around us and the discrimination that we see, in particular people who are Black and Asian, that actually way back in the 60s, immigration was very uncommon, really. I mean, there clearly was. And I was one of the only immigrants in my school. And my father, I can remember facing discrimination, and he left his memoirs, and in them he wrote about how difficult it was for him to get accommodation with 4 children and a foreign sounding surname. Now, I didn't grow up feeling discriminated. There's no way. I was very lucky. I fitted in, but I was aware from him all the time that I had to do better, that it was beholden on me to do better. But Dad, I don't think ever fitted into what he thought of as the established general practice. And I can remember him wanting to appoint a second partner. So he was a single-handed doctor, and there was piles and piles of CVs. And he very rapidly put one on one pile, very rapidly, just read the front page. That's it. So I said, Dad, what are you doing? How are you reading them so quickly? And he said, well, this pile is for those with MRCGP, and this member of the Royal College of GPs, and this is a pile for those without. And at the time, MRCGP wasn't compulsory at all. And he said he was rejecting all the ones that had MRCGP.
I love it. I love it. Sorry, I didn't know it before.
Yeah, and sadly, he felt out of the establishment. I mean, and I think he just felt that he didn't belong to this group, this newly forming professional body, which did fabulous work. So that's what.
You've described him at times as an outsider in relation to how difficult it was to be integrated with an NHS in those 1960s. But you also at times talked about him hating the Royal College of GPs. And, if you think about the irony, or maybe not irony, but actually the ultimate justice in terms of you ending up being the leader of such an organization.
Well, it is slightly odd. He didn't hate the college. He didn't understand them. All he knew, I mean, he had no idea what the Royal College was, to be honest. All he knew was that people that he felt different to were members of this. Now, there were very few people in those days that were members of the Royal College of GPs. Again, bear in mind, it wasn't compulsory, and it was still an emerging exam. This was in the 70s. But Dad had severe Alzheimer's by the time I became chair of the Royal College of GPs. And he I had a 50th birthday at college in Prince's Gate, and he'd already got dementia then. So whilst I took him round and I was vice chair then, he didn't really understand. He had no concept. He had absolutely nothing, he'd no idea what this building was or what, and my greatest sadness is that he never realized that the fear he had of the British Royal College establishment, his daughter had become the second female head of the profession. So, but he never knew. Maybe up in there in heaven, he's looked down upon me.
That's very, very moving. Very moving. Thank you for sharing such a deep personal memory. And actually, the fact you took him there physically, I think, is for you in terms of what you carry with you from those years. It must be important. Now, so let me then, you're obviously keeping doctors in the family, and let me, I can't not talk about your husband as in the immediate past president of the Royal Society of Medicine, because it would look bizarre of me not to. So let me just go, doctor father, doctor husband, and let me ask you this. You may agree or disagree, but certainly in my opinion, from my days as president of the Medical Women's Federation, with Parveen Kumar before me as my predecessor and Nina Modi as my successor, all medical women, very powerful, married to medical men. What is this about? Is it that you marry the job, you marry the everything, you've got a package, or what is it?
Well, if you think about it, medical school and then later medicine, working as a doctor and working in hospitals is equivalent to Goffman's total institution. Now, it might not be in terms of bricks and mortar, but it certainly is as a sort of cognitively based thinking process and bounded by the sort of the beliefs, the values, the systems, the myths. And so you can say it's even more powerful than an institution. And what happens, and I again write about this, is that as you enter medical school, because we are different, doctors, medical students have a longer curricula, a tougher curricula. We're when my sons did sociology and anthropology, they were still in bed at 1 o'clock in the afternoon, whereas we were up doing lectures at night. So gradually your social networks diminish, gradually your friends, as you become medical students and then doctors. And if you think about it, you're working together, studying together, playing together, even loving and suffering together. So it's inevitable that what happens is you form close relationships with other people who are doctors. Now, it's less so now with the expansion of the curricula, and we don't do, for example, dissection, which is really group therapy for 2 years. If you think about around a sort of cadaver, you're meeting 6 of you with a facilitator. Of course, we're there to do the task in hand, but you're also there to talk about the emotional impact of medicine, what's going on, and all the things. So it's not surprising that, and we know from the literature that more doctors marry doctors than any other group. It's just, and of course there's the understanding it. I mean, Simon, we understand each other, the long hours, the long junior hours, the sacrifices that you make, the difficult job. So again, it's not surprising.
Yes, and lovely answer. And I know some people joke and talk about, the competitive relationship you might have, but it feels far more one of loving support as an outsider watching in terms of...
Simon and I are completely non-competitive. Whoever thought that? We're never competitive. The fact that he was on Desert Island Discs and I'm not didn't create any disquiet in this household. Our sons on our 25th wedding anniversary said the one word to describe their parents was competition. So we have healthy competition.
Enough said. Well, thank you so much for sharing some of your family life with us, with all of us tonight. Now, I'm going to move on to a subject dear to both of us. There are many subjects we'll cover tonight that are dear to both our hearts, but substance misuse is most definitely one of them. How did you get into drugs, so to speak? And are we doing okay now in this country, or do you think we could be doing better?
And thank you for asking that. So yes, I got into drugs. I got into drugs by accident because I was at the Maudsley Hospital studying psychiatry, and I had a bit of spare time. I had 8 months after I'd had my first child, and before my first child, but where I had to postpone something. So I did a job in substance misuse at the Maudsley before doing general practice. And Professor John Strang was the consultant, a fabulous man, absolutely fabulous. And he really gave me a sort of free rein to do what I want. And at the time, and this was the late 80s, the HIV had moved into the intravenous drug misuse population. We were hearing stories about up to 70, 80% of drug users were infected. And those were the figures from Scotland, and the figures in England were really quite high. And at the time, my chosen profession, that is general practice that I was going to go into, just wasn't getting involved in the care of these patients. And they had to wait 18 months before they got treatment in specialist services. So they would die on a waiting list. And I started, and I happened to be working with John at the time, and I started what I called a barefoot clinic and a needle exchange unit. And I used to take this suitcase. It wouldn't be allowed now, but I used to take a doctor's bag into this needle exchange place just off the Walworth Road. And I used to take blood from these drug users. I used to do cervical smears on the female drug users, and I used to do antenatal checks for the pregnant ones. And I used to look after them and look after their wounds. And I was really the sort of the barefoot GP. And then I went into general practice, and I wanted to carry on this work. So my practice allowed me, but I also then, with a gang of 3 other, all women, by the way, we set up a model of care around shared care. And I honestly believe the 4 of us transformed how drug users, I think we saved lives, because we took 18 months down to 2 weeks. We trained GPs, thousands and thousands of them. We set up a curricula at the Royal College. We set up shared care services right across the country. We set up a national conference, which is still going. And we got intravenous drug users on board through the Methadone Alliance to help us with this. So it was probably the most exciting time of my life. And I set up a service for pregnant drug users, and because nobody wanted to see these patients. So, and they're very they're the most wonderful patients to care for, because they get better very quickly.
Yeah.
And they're an amazing group. You know, they taught me so much about what was wrong with healthcare and what could be made right. And if you make it right for some of the most disadvantaged people, you make it right for everybody. And I loved it. Now, I did stop. I stopped looking after intravenous pregnant drug users when I started having my own babies, because emotionally it was very, very difficult to see the difference in how my children were being brought up and how these women's children were being brought up. And I then went back to it, but it was very painful for a while to see the inequalities of which, you know, I'm part of it. I was a privileged woman when my children were living in households that had plenty. So, but it was the most extraordinary time of my life. It went on for about 15 years, and then I moved on to other things.
Well, those experiences are unforgettable, and I will share with you. You know, I used to run the caravan, the famous caravan injecting at Paddington Station, and the homeless team in Soho. So I fully agree with you. They did get better, because so much that they had nothing. And
they had nothing, Etta.
And suddenly, you know, you had the right medical care, and of course a wraparound package of the detoxes, the methadone if needed, all the care, the wound care. They all used to come in with swollen legs, etc. So I fully agree. Just because we've
just been kind to them, Etta. You see, the thing was, nobody was being kind to patients. Right. There were signs up saying no drug users wanted here, right across practices.
Absolutely. Yeah, and can I just mention the trauma, because you will remember that nearly all of them had arrived from horrendous early lives, and I think the pain of treating them was containing that, you know, sorrow really for the stories they had to go through, you know, the addicted parents, the abuse that got them onto the train down to King's Cross, you know, etc., etc. We know how that went. Well, just before we move on to your book, tell me if there's one thing you could do to make the current substance misuse and alcohol worlds better in terms of the treatment delivery? I'll leave gambling out because we're going to chat gambling. What would it be? What would it be?
My sense is at the moment we're focused too much on abstinence. And I think, again, what I've learned with drug users is, and as you've said, their end point of drug use is after a lifetime of disadvantage. And I was brought up in what we called a harm reduction model, which meant you put patients on methadone, you didn't penalize them if they used on top, you managed that and you cared for them for the totality. And you got them better. It's ironic, my longest patient actually died of COVID last year, and I'd looked after him for 25 years. And I was very, very sad that what actually took him wasn't his drug use or any of the complications of his drug use. It was COVID. Yeah.
Well, we may come back to this topic later on, but let me just do this for a second. Can everyone see this wonderful book? I bought it for, ordered it for Christmas for lots of my friends and relatives. Beneath the White Coat. I want you to tell us a little bit about why you were driven to writing this book, what it means to you in relation to letting us know about the mental health crisis of medical professionals, and then we can maybe chat a little bit about what the most prevalent ones are.
Yeah, well, the book, I had to write the book, had to write it. I've looked after mentally ill doctors predominantly and dentists for 13 years through the practitioner health. And I wanted to articulate why it is that doctors who have so many protective factors, we've got a stable job, high profile, good income, we have status, whatever people may think, we have flexibility, but nevertheless, doctors have such high rates of mental illness and sadly also high rates of suicide, in particular women. And I wanted to articulate this, not just in terms of the obvious, the high workload, the barriers to attending care, but in terms of what you've just been talking about with me, which is the identity doctors have to their profession, to medicine, and how it is that identity, which I call the medical self, how it's during the process of the development of the medical self that both allows doctors to do the job that they've been tasked to do, which is looking after death, disability and distress, but also puts us at risk of not just developing mental illness, but of actually not seeking help, because one of the rules of the medical self, which is both personalized, so it's both the person and the group, one of the rules is that we don't become unwell. It's patients on the other side of the consulting room that get sick. We wear magic white coats and nothing touches us. Now, so I wrote the book around that. The book, all the proceeds for the book go to my charity Doctors in Distress, which is trying to aim to reduce suicide amongst all health professionals. And I did articulate, and I use my own personal experience. It's a very personal book, which I very rarely talk about. I mean, tonight I am, but it's a very personal book. It's written in the first person, other than the chapters that clearly I didn't write, which are a few of them.
Yeah. So I'm going to get on to some of the. Sorry, there's a message from. Can I just? Someone's sending me something that says, "Henrietta, perhaps we can." I don't know what that means, but someone's sending me a message. I don't know. But can I ask you, Claire? 11,000 people have accessed the Practitioners Health Service. Am I right? It's many,
more now. When I wrote the book, it's probably about 14,000 now.
Okay. So you really understand it, and from what I can gather from the book, there's a lot of shame and a lot of fear still now, despite all the things that medical schools are doing. And I know a lot of the people might have been, also of a young age coming through. You're not just dealing with older people who belong to the generations where you couldn't come forward. So that's very interesting. People are presenting late and in a crisis. Do you think that a lot more could be done if doctors were encouraged to start earlier, in a way what we're trying to do with mental health for the nation, but doing it for our profession?
Yeah, of course. I mean, we must make services accessible, but we also have to understand, and this is what I try to articulate from the book, that what if we have to understand why doctors need to develop their psychological defenses in order to do their job. So if people here are doctors listening, you went and stared at a cadaver first day. Now, some of you may have fainted on that, but you certainly didn't carry on faint. The first time you took blood, the first time you did an operation. So we have to develop the psychological defenses. And in a way, we have to wear a metaphorical white coat. We have to feel that we belong to this special group in order to do the job that patients expect us to do. And what we've got now, I think, is not an understanding of that. We try and normalize what we're doing. We try and say, well, doctors aren't different. Well, doctors are different, and our nurses and others that have to do the tasks that society gives of them. And so, yes, we've got to make it much easier for people to present for care. We've got to look at some of the groups that don't, in particular, international medical graduates, in particular, some of our locum groups, and in particular, some of our specialties, such as surgeons. But we also have to understand why doctors are different. And my sense, Etta, is if we're going to address the mental health crisis, it's about putting groups together, what I call groups of belongings, groups where people can talk about the emotional impact of their work. I work on this, it's 90 minutes for 9 times a year. It's not a lot, is it, in the working hour, in the working day, 90 minutes for 9 times, where we can actually normalize talking about the emotional impact. We can give support and gain support from each other. And those that then struggle on the margins can access services such as the one I run.
Yeah, great.
I don't believe we should all be venting our mental state
no.
any more than we talk about our piles or our fibroids.
Absolutely. No, I understand, and I think you've described it very well. Before we move on, we're going to have a moment where I'm going to look through the 23 questions that our people are asking, and then we'll sort of, this will be our sort of tiny interval break before we move on to the next questions. But in terms of presentations, anxiety and depression, PTSD, what else? People talk about, addiction, obviously, you're seeing. What kind of addiction, out of interest?
Well, addiction is pretty, I was brought up to say that you're not an addict unless you drink more than your doctor. Actually, doctors don't drink a lot. We have rates of addiction lower than the general population, about 7 to 9% in our sample. But of the addictions, if doctors do present with addiction, it's mainly around alcohol addiction, though of course doctors also use drugs, but it's mainly around alcohol addiction. Where I'm surprised, having run the service, is I'm surprised, for example, that doctors, we have a chapter in the book about doctors with autism. Until I met Dr. Doherty, Mary Doherty wrote, I would have said you couldn't have autism and be a doctor. She showed me otherwise, and I'm eternally grateful to her. And to have a look, and also doctors with ADHD and doctors with disabilities. So on the whole, doctors do not suffer from different illnesses to their patients. They just suffer in different proportions. So there's far fewer doctors, for example, with bipolar disorder, though it is not uncommon. And we've now got 200 doctors with bipolar disorder. Some doctors have schizoaffective or schizophrenia, but not many. The predominant diagnosis we have in the service is depression, anxiety, a new diagnostic category called NHS-itis, and then we have a sort of category of a total mess. So people who leave it so late to present that everything but their work begins to fall apart.
Thank you. And now I'm going to move on to some questions. We've got a lovely comment from Michael Myers saying, great conversation, remarkable, kind, interesting, physicians, wonderful preamble to the book. So that's kind.
But Michael Myers is a wonderful physician in America who's just written his autobiography on his experience as being a doctor, who does spectacular work around doctors and doctors' mental health. So thank you, Michael.
Excellent. And actually, you've just reminded me, you mentioned John Strang earlier on, Professor Sir John Strang, one of the fathers of addiction research in this country. And I think we probably didn't do enough justice to his name, in case people want to look him up. Someone's Abby Backer saying it's a great book, talking about your lovely publication. Catherine Royce, talking about how can society view addiction as a medical rather than criminal issue. And I think this is absolutely so. Maybe would you like to say something about this?
Oh, well, I absolutely agree with you. I think it's very harsh to be treating people who have clearly an illness as criminals. I mean, we see this in doctors where they have multiple jeopardy. They may well be arrested by the police and go through a police process and a trust process and a regulatory process, and it can take 5, 6, 7 years because they may, be addicted to painkillers or have been found with stimulants on them. So I agree, but sadly it's a political decision and not in my hands.
Yeah. Next question from Bradley, saying, "Dear Clare, you've been extremely active in the reform of the GMC towards doctors with health problems. Could you say some more about what you think could be done to develop this?"
Yeah, thank you, Bradley. Yes, I mean, I have. I've worked, because I've been running practitioner health for so long, many of our doctors have fallen foul of the regulator. And if you think about it, there's an overlap between performance, health, and regulation. So the obvious one is what we've just been talking about, drug misuse, but there are many others. And the GMC very early on identified that a large number of doctors who went through their processes sadly killed themselves and started a reforming agenda. And I'm pleased that I've been part of that reforming agenda, working sort of, I suppose, in the start agitating the GMC, but now working with them. And the GMC have transformed the way they work. They have made enormous changes. There's more still needs to be done. They'll accept that, but they've made enormous changes to things, very simple things that make a lot of impact on doctors, like when you receive the letter. Please don't receive it on a Friday or a Saturday when you might be alone. How you receive the letter. At the beginning, a woman would be in hospital with postnatal depression and she'd get a letter to say you are under investigation. Well, it doesn't do much for your mental state. They've also changed the way that they manage their processes. So there's a way to go, but it's on a reforming agenda. And I think the way they treat doctors now with health problems, I think is certainly not as punitive as it was 10, 15 years ago, which sadly was, of course, coming on the back of Shipman, where everything changed.
There's a beautiful message from someone called Natasha saying, "Thank you for saving my life, Clare." So that's rather beautiful.
Natasha, thank you very much. And I know who you are. I think I know who you are. And you saved your own life. You were courageous enough to give your voice at the places and the times that you needed to.
We have had quite a lot of questions about gambling. I was going to do this later on, but the number of questions are piling up, and it's really, I'll pick one, but there are several. Martin Jones saying, "You both have an interest in disordered gambling. What can be done to get the NICE guidelines project moving?" I can see Henrietta was calling for this at least as long as 2016, but NICE website still has the same message today as it did in 2018, work not yet programmed. I think to introduce this, we might, Clare, since we are moving in terms of time and we have only an hour, we might just talk for a moment about your newly established primary care network for the identification and treatment of gambling disorder, and your interactivity in terms of the NHS providers. And then I think we can touch on those questions.
Yeah, well, I started my career in drugs and I'm sort of coming close to ending my career in gambling. So there's clearly a sort of message in between that there's something about addiction that drives me to wanting to care for patients with various forms of addiction. So gambling is very similar to how substance misuse was way back when, in that services like yours, Etta's fabulous service, but on the whole, very few services. GPs not at all involved, because I didn't get any training in gambling and I did an addiction job and an addiction rotation. And what I wanted to do was essentially to try and create the same that I did for substance misuse. So I run a shared care service we're working very closely with yourself and with others to try and create what we call a competency framework and then a training program. We've got resources to put into practice. We've created a network across, at the moment, London, and COVID has sort of slightly changed how we set it up. And we're trying to turn a long waiting list into a short waiting list. And the gamblers are coming, not in the numbers that we wanted, because it's hard to get referrals at the moment because general practice is working in a different way. And they are very similar to the patients that I used to look after nearly 30 years ago. They have multiplicity of problems, of which gambling is one of them, but they have, as you know, Etta, serious deprivations in other places. They have high incidence of other mental health disorders, and they get better as well. Maybe not as quickly in terms of the quick fix, because there isn't a quick substitute medication, but there are ways that we can get patients better, and there are ways that we can put in place to stop them doing more damage to themselves and their families. And I love it, and it's been running now 18 months. Primary care gambling service, you can look online for it, and if you're listening to this and you have patients who are gamblers, please contact us. At the moment we're London, but because of COVID it's easier to do across London, because at the start we were only going to be South London. And yeah, it's an amazing area which I never ever thought I would find my way into in the tail end of my career.
Although if you look back, you will recall that in 2009, when Julia Neuberger was chairing the Responsible Gambling Strategy Board, you and I were called in to draft that paper to bring GPs on board. So it's taken at least that long.
Yeah,
and it's taken you, actually, eventually to properly do it well. And it is a highly, highly evidence-based service and a very welcome.
Well,
and
thank you for saying that. But it's about, see, GPs, you can't just say to GPs, this is what you have to do, because it's not fair. And that's what was done with drug misuse. You've got to acknowledge that GPs need the skills, the time, the competence, and they need to have pathways to refer patients onto. But yes, you're absolutely right. We were looking at this, well, 13, 14 years ago.
A very long time ago. Do you think we have parity of esteem yet in terms of gambling disorder in relation to other addictions or indeed mental health? That's my last question on gambling for you.
Not at all. I mean, we only have 2 codes for it in our system. We have no patient information leaflet. We have, as I said, till I started in this field, I had no idea how prevalent it was. I had no idea about its link to suicide, particularly male suicide, linked to other mental health disorders. And I've spent my entire life in the field of addiction. So not at all.
Yeah, absolutely. So the answer is absolutely no parity of esteem as yet, but we're working hard on it. And with the Gambling Act review, hopefully imminent work will be taking place. Now, Claire, mentioning Julia and our proper first piece of work together in 2009 reminds me, I promised you I'd mention the Gerada scale. Have you ever heard of the Gerada scale?
Never.
Okay, well, I invented that. I'm going to share it with 1,000 people. So when I came to meet you, you were at giving this lecture in one of the biggest halls in Westminster. There were literally thousands of people in that hall. And I was standing on some balcony looking down, because you're supposed to meet me after. And I literally just watched you in action and saw you somehow propel yourself higher and higher and higher in kind of getting all these people to totally agree and follow with what you were trying to get them to do. And I was standing there thinking, oh my God, that's how it's done. And it was a real sort of moment for me, a professional moment I'll never forget. And so for the past, forever, 10 or over a decade, I have this vision of, when I'm in really difficult meetings, normally they are actually government meetings, when you're trying to persuade people to do something that's very important. I change gear. So I'm driving along and suddenly I go into the Gerada gear, which allows my little car to suddenly fly above everything and everyone, and you just go, nuclear on what you're trying to get across. And so it's Gerada Force 10, which is what you work at all the time, but a lot of us are sort of slightly lower on that scale normally. So that's it. So now I've gone public on my trick when I need to pull that. Now there have been a lot, onto serious stuff again for a moment. There have been a lot of questions, Claire, on the leadership that you showed at probably what I feel might be one of the hardest times of your life. You rarely talk about it. Things were difficult for a few years as you put the NHS, you put the college's needs before your own in fighting, let's say, fighting a bigger battle than maybe you wanted to, or you could, but you did. Do you want to talk a little bit about either fear and leadership or loneliness of leadership? I mean, you've got the platform. If you feel like it, it's a very big question.
I think you're talking about the Health and Social Care Act. So the joke is, I became chair of the Royal College of GPs, and on the Friday, you take over and you become the chair on the Saturday. And on the Friday, I got a phone call from a journalist I'd spoken to the previous month, and he said, "I just want to check a few details with you." I said, "Fine, absolutely fine," and my father's name, and when I qualified. And then he said, "Claire, I said this was going to be in the centre pages. Well, actually, your first page, front page, second page, third page, and it's been syndicated to the other newspapers, and you're going to be the top of the item on the BBC." And I said to him, this is Dennis Campbell, Dennis, if you're listening, I said to Dennis, "What have I said? What did I say?" And what I actually said was that the Health and Social Care Act 2012, and this was 2010, was an error, and that it was unnecessary. It wasn't going to solve anything, and it was going to put patients' lives at risk. And I was called a socialist. Somebody said, "Oh, she's a socialist," and it was as if it was some sort of insulting comment. And bear in mind what I've talked to you about my father. As far as I'm concerned, if we don't make things right for the poorest in society, there's just no point being a doctor. So I was actually challenging the Health and Social Care Act, and I was the very first medical leader to do this publicly. And it was very painful. I turned up for council the next day thinking they would sack me before I'd even become the chair, because you go through this formal procedure. They were all carrying the copy of The Guardian, and I thought, oh my God. In fact, they were wonderful, absolutely wonderful. And that weekend, I was contacted by about 50 or 60 people giving me advice. Some were saying you should retract what you said, not my members, by the way, and others said, "Thank you very much for saying it." And over that course of that weekend, I understood what leadership was, that leadership is about making a decision. Now, the decision might be to do nothing or to do something, but leadership is about making a decision, and you cannot delegate leadership in that. I could take all the advice I wanted. And so that was what it taught me. It also taught me the loneliness of leadership, that again, and I see this repeatedly, even during COVID, looking at our leaders, you can be critical of them, and I won't be critical of leaders in the midst of a pandemic, apart from one who's no longer a leader. I won't mention his name. And because it is a lonely place, as long as they're not doing it malevolently, you have to make a decision, and it may well be the wrong decision, but you have to make a decision. So, and that's what I learned about leadership. I also learned how difficult it was for me, because for a long time I was a lone voice. I felt, really, am I right about it? A little bit in the book. I felt demoralized. If anything, in retrospect, I probably was depressed. I certainly lost a lot of weight and couldn't sleep, had paranoid ideation, though I think that was true. I think people were following me, not in the same way, not in a psychotic way. So that's the message I give to leadership. And I've since written snippets about it, and I recently wrote a BMJ top tips for leaders, of which one of them is, and Simon was very good, Simon, my husband, because there's one thing, if you make an error as a leader, there's no point your nearest and dearest telling you that. What you want is for them to put their metaphorical and physical arms around you and hold you, and then at some point later on you can do a sort of debrief and say whatever. So I learned a lot. Now, oddly, we now have a reversal of the 2012 NHS Act, or parts of it. And I think, I have to say, I think I've been vindicated. I think that what I said was absolutely true. It was an unnecessary piece of legislation. We should have moved towards integration, not competition. And actually, you know, I learned a lot, and hopefully others have learned a lot.
Well, what can I say to that? I think it's a privilege to hear you speak so openly and honestly about.
And at the time, I was one of the only female leaders, and I'm not saying that because that it wasn't just lonely in being out there on my own, but there were very few people. You know, all the most of the Royal Colleges were run by men who were very well established, had come in way before me, and I understood then what probably my father felt like at being an outsider. And I'm not saying that because they were facilitative. It was, you know, they were, the places I was inhabiting gave me support, but it was probably me that found it difficult to get the support that was being offered because of the difficulties of what I was going through in terms of the press. I mean, one particular time was I think it was the Independent printed a picture of my home on the front page, and you know, like you see, and all they say is house worth, because they don't know anything else. They just look on the internet, and it looked like a sort of, they'd made it look like a sort of brothel that I lived in. And on more than one occasion, I had to lock the door, put the curtains down, and say to the boys who were still quite young there, if the doorbell goes, don't answer it, because I was worried the press would doorstep me.
Claire, when did that fear finally leave you? The
fear has left. It took a long time. I think leaders have fears. You see, I think any leader, I mean, doctors have fears because you always fear you're going to do the wrong thing in the consulting room. So fear is an ever part of what we do. But the fear really left me a couple of 3 or 4 years after admitting office, because you're still, but again, I don't want to put people off leadership roles. I think it's what's not taught to you in these leadership schools and leadership classes and leadership books that you talk about, is the fear of leadership, the fear of doing the wrong thing, of being exposed, and actually the need to make a decision, even if that decision is to do nothing.
Were there some people who were high up enough to have potentially risked openly supporting you, but did, who you now still remember?
Oh gosh, yes.
And feel close.
Peter Carter at the Royal College of Nursing was spectacular. Other presidents, and I won't name them, were spectacular. And of course my own college. I mean, to a man and woman, my own president, Iona Heath, my own council, were absolutely fabulous. We were the first college, by the way, to survey our members. And then every other college was forced to do that. But it wasn't just the Royal Colleges. I don't want to put the slur on them. I think it was just, I think before I spoke out, what Royal Colleges did was they worked inside the tent. The number of times I was told you work inside the tent and not outside the tent. And I think, for quite rightly, you don't want on every single occasion senior medics talking to the press and exposing the government. But actually, there are times that you have to do something like this. And I think when we had the junior doctor strike, I think a lot of senior medics spoke out in favour of the junior doctor. So I think things have changed. I don't think it will ever be like that again. I don't think
I agree. That loneliness that you experienced, I agree. And there are other reasons, you know, social media, etc. There are positives and negatives about bringing the force together. Now, there's a man called Simon who keeps on sending messages on the Q&A. He's sent many asking whether you're going to end up on desert island discs, what your favorite object to bring with you, a luxury item. Now he's asking what your next job might be. What Claire, what would your next job be now? What still needs to be done?
Can I say something? It's not a silly question. Till very recently, I would look at the job page, and the advice I give to people, especially younger people, is even if you're in a really good job, always look to see what you could do next. if there was a job that I'd like to do, it doesn't exist. It doesn't exist at the moment. But the job I would really like to do is around heading up some sort of health and well-being arm's length body for health and care staff, something that was a parallel to CQC, similar to the National Speaking Out Guardian. I think if that was anything that would entice me away from what I'm doing at the moment, it'd be something like that.
Yeah. I can see you enroll, and by tomorrow there'll be some email coming your way, probably saying, "What a great idea, you're on." So, well, let's talk for a second about professional fulfillment. I often ask people about how they feel they've made a difference. Now, for you, you've made a difference to so many people in so many different areas, and that's why you're so, happy in a way with your job and what you do. But is there one thing that you've done that stands above all else in terms of looking back across your career?
I think having two children who are sane, don't hate us. To be honest, Etta, I think just even having talked through here, I think the single most, if I was to really look back, I think the work with drug users, you have to understand, and people who are younger don't understand this, these patients were dying. They were dying rapidly. The focus was particularly on gay men. There was no focus on intravenous drug users until Roy Robertson in Scotland. I think it was 70 to 80% of his sample were HIV positive. And just shaking the hand of a drug user, they would look at you as if you were, oh my gosh, you're shaking somebody's hand who could be HIV positive. And we forget this now. And so I think that period of my life, setting up services, changing the landscape of how drug users were managed, and then carrying that work into the current work with my practitioner health service, because they're very similar, by the way, for very different reasons. Doctors and the homeless, because I used to look after the homeless, similar barriers to healthcare, similar stigma, but very different populations.
There are now, 58 or whatever things. Now, someone's suggesting you should be the CEO of the Gambling Commission. Now, there are several jobs in gambling, Gary, and I would agree that, so do have a look at that paper. Someone saying, thank you both for a wonderful interview. Claire, you are amazing, from Sue Warren. Someone saying, help, we still haven't sorted out the nice guidelines, and you two are sitting there chatting, and you haven't answered this. Yes, so let me answer that, because this poor Martin is keeping sending messages. I truly think they're selecting their panel, and it will have to be people who will then be able to be a good chair in order to get the evidence from specialists, in order to understand how to start randomized controlled trials and the evidence base needed to provide funds for the right treatment for gambling disorder, yes. I would say.
But can I also say, and Stephen Wilmot has taught me this, who runs, who's a GP who works with something called substance misuse for general practice, gamblers are closer to our GP patients with chronic disease, multiple morbidity, than any other patient that I've managed. So whoever's asking the question about nice guidelines, I would actually say maybe subconsciously the reason we haven't got nice guidelines is because actually what we'd do is it would pigeonhole gamblers into a box that they shouldn't be put in, unless you're dealing with very specialist forms of interventions that ETA does. Because gamblers, as I've already said, have high incidence of depression, anxiety, schizophrenia, learning difficulties, homelessness, forensic histories, and they need an arm around them and a holistic care about them. And gambling is one bit of this multiple deprivation and multiple morbidity that we see.
Claire, we are coming to the end of our time, and I want to ask you something about the Damehood. It's such an enormous thing to happen. I have no idea how many there are, but they're very, very few. You're now Claire, Dame Claire. How will it impact on your life? What does it mean to end up in this sort of recognition? What does it mean to you?
It means I'm no longer in competition with my husband, who's of course a knight of the realm. I am I think the first person of Maltese origin to get a Damehood, and only the second Maltese, the first one was somebody called Sir Adrian Dingley. It's not going to change my life, of course it isn't, but I think it's a sort of showing that the powers that be forgive me, which sounds really naff, but I think it shows that maybe we're now in a different place, and some of the people now I admire, really do admire, people like Jeremy Hunt, for example, who does amazing work in the health commission, health select committee. You know, I couldn't believe that years later I would be able to say that I think he's amazing, and many others. So I think it's put that period to bed, really.
Beautifully said. And I think on this note, unless you have any lasting thoughts to share with all the people here tonight, do you?
Only that somebody's asked what the title of the book is. So it's Beneath the White Coat: Doctors, Their Minds and Mental Illness. All donations to charity to stop doctors and health professionals killing themselves. It's a good read. You'll learn a lot, and you'll learn a lot about me.
Thank you. That's fantastic. And on that note, just stay there while I do the bit that I really want to do about letting everyone know that these evenings, like tonight, are attended by thousands and thousands of people, and they're totally free for anyone to watch. However, we do really encourage you to donate, even a small donation if you've enjoyed this evening, because a little bit from all of you would go towards allowing the Royal Society of Medicine to continue with its educational mission. And if I know many of you have been listening every Wednesday night to these evenings, and of course the thousands of you who attend all the COVID, I think we've had over 70 COVID seminars, webinars, and so to do all this we do need funds, so please do donate if you can. Next week we have our lovely President Roger interviewing Professor Dame Leslie Fallowfield, and I very much look forward to seeing you all back with us. And Claire, thank you very much. I know we see each other regularly, but to see you in public with your great persona and your Gerada scale 10 has been a real pleasure. Good night.
Thank you very much, Etta.
Bye.